The next is going to be a tumor board on neuroblastoma. I invite Dr. Ramesh S., Head of the Department of Pediatric Surgery at Indira Gandhi Institute of Child Health, and Dr. Deepak J., Department of Pediatric Surgery, Indira Gandhi, to moderate the session. I also would like to invite panelists now to the stage. Dr. Sajid Qureshi, Head of the Department of Pediatric Surgery from Tata Medical Center, Mumbai. Dr. Mukta Ramadwar, Head of Pathology from Tata, Mumbai. Dr. Vikramjit Kanwar, Head of the Department of Pediatric Hemato-Oncology, SIMS Hospital, Ahmedabad. Dr. Saurabha Kumar, Radiation Oncology, Narayana Hridayalaya. Dr. Karthik G. Ashok from the Department of Radiology in Narayana Health City.
This is a child, 1 year, 7-month-old male child. This child presented with a swelling behind the right ear since the age of 3 months. It progressively increased in size to increase to the size of around 10 into 9 into 7 centimeter, formed to hard lobulated mass with the skin which is stretched. The general examination of the abdomen CNS was all normal. And a CT scan was done. These are the images. Dr. Karthik, you want to comment on the CT scan images?
Yeah, this is axial section of the head with contrast. There is no plain CT in that. You can see an exophytic mass in the right occipital region with a soft tissue component more with, probably, I'm not seeing the bone window, so I won't be able to tell more. Anything more we can add?
I have one more image.
Yeah. It looks at different stages of the disease, or it is the same cut?
It's the same cut.
So it has got a large soft tissue component, and still bone window would have been preferred, and it looks like this is a plain CT and the first one was a contrast CT. Yeah. So not much calcification in the tumor, no intracranial extension, and it is a broad-based scalp involving soft tissue density lesion. I mean, in CT, the problem with this is hypodense areas are really solid or cystic is very difficult. Maybe one ultrasound would have added that is it a solid tumor or something, it's a cystic lesion. So I would have done an ultrasound to see whether it's a solid lesion at the same time before concluding.
Yes, sir, Sajid.
I think the clue is we are sitting in a neuroblastoma session, so I would say this is a neuroblastoma.
Sir, would you like to comment on the bone, the adjacent bone?
There is some periosteal reaction over there, not a lytic area actually. Completely lytic area is not there. So differential would be primary tumor versus a metastatic tumor. So we need to do a abdomen or a chest CT in this setup, yes, or an abdomen ultrasound.
Okay. So CECT was reported as a focal lytic destruction of the right occipital bone with adjacent heterogeneously enhancing soft tissue component. There was a focal contour bulge in the subcutaneous tissue and skin of the scalp with focal extracranial bulge. This was the report from the radiologist. There was no evidence of calcification or fat component seen. The brain was normal otherwise. As I told, the CECT thorax, abdomen and pelvis was done and it was normal. And a MIBG was done. This is at presentation, sorry. And this was reported as a tracer uptake only in the occipital region. There was no tracer uptake elsewhere. So where do we stand now, sir?
This is interesting. But what made you ask for a MIBG scan when your CT thorax, abdomen, pelvis are normal? Why was your suspicion going towards a neuroblastoma? Let me pose this question to you.
Yeah. So,
okay.
We do have biopsy also.
See, we are getting it out.
We'll do it. See, at this stage, the differential diagnosis, what sir thought was a soft tissue sarcoma, metastatic neuroblastoma, and Langerhans, which is histiocytosis. These were the DDs which the medical oncologist thought. And then a FNAC was done.
So based on your pathological diagnosis of neuroblastoma, you went ahead with an investigation to look out for a primary site, because definitely you think that this is a metastatic site, not the primary site. This is not the site of having sympathetic tissue, so it is probably a metastatic site. Now, why the MIBG, which is so specific for neuroblastoma, didn't pick up anything? Now, it may happen that we may have a non-avid MIBG, non-avid tumor. But for that, the metastatic site should have also not have a avidity.
Yes.
You cannot have a differential avidity, the primary avid and the metastatic, and vice versa. So this is really, we are stuck, a point to ponder upon, but I may not completely exclude the primary site somewhere in the abdomen or in the thorax. It may just happen. The other problem is we are having a iodine 131 scan, which is not very specific for the diagnosis. It is very specific for therapy. Iodine 123, and that is drawback in the entire country. It's not that you are having a problem. The entire country is facing a problem. We don't have iodine 123. So I would give away to that probably the primary site is not taking up iodine 131 because it is small. The avidity proportion would be different. So I would say that. But I would not exclude this cannot be an isolated metastatic site, unknown primary, though unknown primary neuroblastomas are documented, that this is very weird to have at the occipital site where no sympathetic tissue is present.
Yes, sir. Now I have pathological Shimada classification of the needle biopsy specimen showed as a neuroblastoma differentiating, and IHC was done. These are the images. If Mukta madam would like to comment on photomicrographs.
Okay, let me have a look at this. Can I see any glial tissue here? I cannot, but maybe it's there. So yeah, essentially it is a malignant round cell tumor, and in this particular case where I'm not seeing any glial tissue, I would like to run a few markers, immunohistochemistry markers, which I think has already been done. And also considering the odd site, because with this morphology, there are two distinct, histologically two distinct differentials. One is obviously a metastatic neuroblastoma at that age, and followed by Ewing sarcoma. So considering these two diagnoses, I would like to run a panel of markers. I wouldn't do too many of them because if it turns out to be a neuroblastoma, I would certainly like to have my tissue for further molecular testing. So if it was a conventional histology, which in this particular images I don't see, I wouldn't even run any immunohistochemistry. But in this particular case, it's such an odd clinical situation. I think it is indicated.
So as I told before, these were the panel of IHC which was done.
So the only thing I would quickly add is for Ewing sarcoma, in general, those patients tend to be older, typically older children or adolescent group. And a lot of times you can see the tumor arising within the bone plate and extruding outwards rather than being an extra-osseous site eroding inwards. So this would be atypical for a couple of reasons, but definitely part of the, given the small round blue cell, absolutely part of the differential.
So just one question. As you said that it may be MIBG non-avid, and as ma'am also told that she's keeping two diagnoses in mind, metastatic neuroblastoma versus Ewing's. So even after this, now the biopsy is giving as neuroblastoma. To make the diagnosis, will the PET-CT have any role?
That's a very good question, Gaurav. So the question is whether the PET scan will be more informative than MIBG in terms of...
MIBG we have done.
Okay.
We are not finding that there is any primary. So we found that this is the only occipital region which is the MIBG avid this thing. And as ma'am said, she's keeping Ewing's also as a DD, differentials. So now before proceeding or to make a diagnosis more firmer, will we be getting any more info by getting a PET-CT done along with MIBG? MIBG is done already because that biopsy came as neuroblastoma. We did an MIBG to look for the primary, primary was not found on MIBG or any thorax or the usual site. So now, going ahead, before planning for any treatment, PET-CT will have any role?
Got it. That's a very great question, Gaurav. That's a very great question. The answer to that is PET scan a gold standard? No.
No. Yeah.
MIBG is the gold standard. Can PET scan become the gold standard, or can it just push MIBG and become the one? The literature says maybe not. But we did a study where we compared MIBG and PET-CT and bone marrow examination. And what we found, the findings were really good, and we are moving more towards maybe PET scan maybe become the gold standard for MIBG. It may not displace MIBG, but yes, in difficult situation like this, and especially when it is non-MIBG avid, a PET scan will be more informative than an MIBG. In fact, it is recommended in the pre-PET-CT scan area, if you have MIBG non-avid disease, a bone scan was compulsory. Now that has been taken care of with a PET scan. So what we found, whenever there is MIBG positivity in the bone marrow and confirmed with a bone marrow biopsy, the PET scan is always positive.
But this all, the PET scan where we are saying that it may substitute or give more information, this we are doing when we are doing MIBG only with iodine 131.
Right.
Or still if we get iodine 123, then also it will be the same, or?
The question, the situation will be different. I don't know because we don't have 123.
Yeah,
I cannot answer that.
it.
But yes, we have used and we have found benefit of PET scan. Though we have not reached the stage of completely replacing, because iodine, MIBG is having its own problem of availability once in 15 days or 1 month. Many centers do not get that. So yes, we are moving, and PET scan is readily available at every nooks and corner of the city. So yes, PET scan may be having a good role, and especially in difficult situation like this where it is non-avid, or when the primary is not lit up and we know that this is not the primary site, this is a metastatic site. So maybe you have a different answer with PET scan.
So, sir, maybe you'll suggest
Thank you, sir.
probably a PET scan would have been helpful in this situation for this case?
I would have not been dogmatic about that because MIBG is avid at some place.
Okay.
But yes, when you don't have a primary site and when you suspect, yes, there should be a primary site, maybe PET scan would have helped in identifying the primary site.
I'll just add a couple of quick points, and this is an excellent question. So just 2 quick points has been emphasized so importantly that PET scan is still an evolving technology. If you have a small primary site, like a small adrenal site, you may not pick it up even with PET scans. So it's not like, yes, it's something that's interesting, but may or may not be helpful. However, given the lack of availability of 1, 2, 3 iodine MIBG, we'll be recommending PET scan as the scan of choice moving forward in the upcoming protocol, which is opening next month in INPOG. And the reason we're doing that is many centers are unable to get access to MIBG scanning. So what is happening is that they're ending up doing nothing. They're either doing no scan, or they're doing PET scan, but doing it off the record, so we can't track the results and see how accurate they were. So PET scan is going to be used, you can call it experimental or an experimental format, but starting next month in the neuroblastoma study, that will be the nuclear medicine scan of choice. And not out of because we want to push forward that way, but simply because we don't have access to iodine 1, 2, 3.
Thanks.
Going further now.
So, what about the role of optrioid scans? Because in our city, that is easily available.
Sorry, the role of?
Optrioid.
Oh, okay. I'll let you answer that, Sajid.
No, we'll discuss that a little later, probably. Yeah. We'll go ahead. Regarding the panel of immunohistochemistry, ma'am, these were the ones which were done. And as it's seen there, synaptophysin and chromogram were positive, the others were negative. Would you suggest to add something?
No, here the important thing for me, as far as my own differentials are concerned, is that MICTO is negative. So that kind of rules out or excludes Ewing sarcoma, although neuroblastoma is always the first differential diagnosis, and synaptophysin and chromogranin positivity supports it. So I think I'm okay with the diagnosis of neuroblastoma.
Yes. So these are the images of chromogranin and synaptophytes in immunohistochemistry. Any comments here, ma'am?
No, they are positive. I take them as positive.
Okay.
That's okay.
So a bone marrow biopsy was done. Marrow was not involved in this particular case. Questions for the board, as I was asking before. Now, is it L1 or L2? Image-defined risk factor, should we take it as positive or not?
My basic question remains that, is this the primary site or the metastatic site?
That's another thing.
If this is a primary site, which I doubt because of general knowledge that there is no sympathetic tissue here, this could not be. But we have seen unknown site. We have seen cerebral neuroblastoma also. So that thing is there. But I would not place the local risk stratification on this metastatic site because there are no features which are for L1 and L2. L2 features like neurogenic, vascular, infiltrative, extensive, you cannot. You can say that infiltrative, it is going inside the calvarium, it is going infiltrating the durameters. Those are the high-risk features. They could qualify for L2.
Okay.
But apart from that, I would not like to apply this L1, L2 business a year.
Basically, the first thing is whether it's a metastatic lesion or a primary lesion. So probably L1, L2 might not arise. Still, we are clear about whether it's a primary or a metastatic lesion. Any other differentials? I think we have discussed about the differentials. Shall we go ahead, sir? Considering that this is neuroblastoma, in our particular case, for various reasons, NMIC amplification was not done. So please comment on NMIC status and what is the role of that?
Okay.
How important is that?
Right. This is an infant. We have to go ahead with NMIC testing. And not only NMIC testing, we have to also, you have just listed the other genes as well. So we have to go ahead with the ploidy and 1p11q and 17q gains. So it is essentially in an infant important to have this multiplex gene testing. It's important for prognostication.
Actually, we made a diagnosis of a primary tumor of the occipital region, INRG staging L1. And a neoadjuvant chemotherapy was given, 10 cycles of vincristine and cyclophosphamide with 2 doses of adriamycin. Any comments on this, sir?
Can I just ask?
Is a
Sorry,
little different from what I have written. Dr. Apaji sir would be able to comment if you have any queries regarding that.
So can I just go back very briefly? So I know a lot of times getting genomic testing is difficult, like so NMIC, etc., is expensive. You may not be able to get it from the family. But did anybody check the LDH and the ferritin on the patient? Because those can be surrogate markers for high risk. And I didn't see anything in the results displayed.
LDH and ferritin were done and they were normal.
Dr. Deepak, before we go ahead, like even at this stage, should we continue to talk about this case as a primary occipital neuroblastoma, or shall we change our tracks and
Yeah, sure. If I agree with you.
let's take the vote from the audience? I mean, because the entire situation will be different if we are treating this like a metastatic neuroblastoma.
Yes.
Yeah, just as a learning point for myself, more than anything else, when a patient presents like this.
Please introduce yourself.
Yeah, hi, my name is Prasad, I'm from Singapore. When a patient presents like this, it's for learning purposes. Would you be happy to just do an FNAC? Secondly, would you be, I didn't see any catecholamines here. So I'm still debating in my head whether this is actually neuroblastoma. I mean, yes, you got your synoptophysin positivity here, but that's on a basis of an FNAC. We don't have multiplex details here. So I'm very uncomfortable.
A needle biopsy was done.
I saw FNAC.
Biopsy was
That
done.
was a
Okay,
biopsy.
okay. But catecholamines? You didn't do catecholamines. Okay. But are we sure that this is neuroblastoma is my question.
How important is doing catecholamine? What's your comment on that?
If you are doubting the diagnosis, the INPC criteria for diagnosis is when you have an unequivocal histological evidence of neuroblastoma that confirms the diagnosis, which we have, that's why they went ahead, Or if you have a bone marrow which is positive, in a patient with elevated urinary VMA, there comes the role of catecholamines. But when you have a histological unequivocal confirmed with IHC marker, I don't think the diagnosis is at stake here.
No, Sajid, it's not very easy situation in this particular child. If like I'm thinking of this child coming to our clinic and I'm getting a biopsy from an occipital mass with no other primary, I mean, I said I have only 2 differential diagnoses, but even that is not easy. Before, I will never offer the diagnosis of neuroblastoma only on this morphology and only on that immunohistochemistry. I will have to have the MIBG positivity here. And if MIBG was negative, just for instance, it will not be called a neuroblastoma just by the mere presence of synaptophysin and chromogranin, because this can be present even in some other sarcomas, sometimes even can be non-specific. They are not very categorical markers for neuroblastoma. So I would definitely have something that supports my diagnosis of neuroblastoma clinically or on the MIBG scan, and I was comfortable in this case because of MIBG positivity. Otherwise, I wouldn't have, and then maybe I would have gone a step ahead and told and have asked for molecular markers, at least an EWS-R1, the FISH probe. And if it was also negative, then maybe the closest other differential diagnosis was maybe we are dealing with a poorly differentiated round cell tumor, an undifferentiated sarcoma. And then that becomes like a game changer as far as the treatment is concerned. Here we are not getting a primary, so diagnosis of neuroblastoma itself is in doubt. So if we are calling it an undifferentiated sarcoma, that becomes like a Ewing's family of tumors. So it's not a very easy algorithm here. So positive MIBG is really helping us to diagnose, not just the immunohistochemistry. I take that point very.
But congratulations to your pathologist. Her diagnosis of neuroblastoma was confirmed later with an MIBG. Thank you.
I would have said definitely one should have done a EWS-R1, FISH. If there's the slightest doubt, before calling it definitely, before excluding Ewing Sarcoma.
Yeah. And this problem is not just at this site, even suprarenal tumors, when they are so undifferentiated. It's a very hard situation, and there we take the same approach. I would never offer that diagnosis before I have the MIBG and VMA with me. It is a supporting factor. It has to be.
Okay, we'll go ahead. Right now, ma'am, probably we'll take it as neuroblastoma and continue the discussion.
Yeah, MIBG, you have right.
That again is, time should be said. Right now, we are not sure about that again. We are taking it as primary probably. So this was the neoadjuvant chemotherapy that was given. However, the response assessment, clinically the response was very poor. The mass actually continued to increase in size. As we can see in the photograph, there was a bit of ulceration. Radiologically again, can you comment, sir? Anything additional from the previous one?
No periosteal reaction has appeared after the treatment. As you see, on the occipital side, if you compare the previous and the present, more of a periosteal reaction has appeared. I don't know the size. Definitely it has increased periosteal.
Okay. So essentially there was no response to neoadjuvant chemotherapy in this case.
So tumor board is always easier for us because we pay armchair experts, and it's much harder when you're in busy outpatient. But I was just curious, there seems to be a long delay between deciding there's no response and actually starting treatment. Whereas for most low-risk patients, typically within a couple of cycles, if you're not seeing any kind of response, you will question your risk categorization. So was there any specific reason? I mean, was the patient lost to follow-up, or did they sort of not get assessed in between? 10 cycles, I'm assuming, is at least sort of about 20 weeks or more.
Yeah, so was...
30 weeks, right.
So did we do the MICAN at all?
No.
And the MICAN was never done. So I'm just curious, if you saw no response after a month or two, I would have strongly questioned the course we're pursuing.
Okay.
Be that as maybe you went ahead. Sajid, what would be your surgical plan?
So now
I would like to definitely see more images. The position of this tumor is making me believe that we are close to the transverse sinus, we are close to the sigmoid sinus, and excisional surgery, a GTR in this situation is going to be a craniectomy occipital bone rather than this thing. And for craniectomy, I need my dural sinuses safe. If the dural sinuses, especially the transverse sinus and the sigmoid sinus, are involved, I would be a little reluctant. So if I have evidence that the dura is fine, the sinuses are fine, I would go ahead with a craniectomy because this bone is expendable except the region where you have the sinuses. So that will be my take, and I would certainly do more, like to see more scans, and CT scan only, because CT scan is the best rather than the MRI.
Sorry, sir. We have only these many images.
Meningeal enhancement, everything, I think MR would be one additional. Actually, I've done 2 CTs. One MR would give a more additional information rather, I believe. When transverse sinus also, it will help also.
So, we was, yes.
Just quick question with regards to differential diagnosis. Could it be melanocytic neuroectodermal tumor of infancy which has got local expansile growth with the MIBG avid, which can arise from commonly from maxilla, but
I did not think so, looking at the images that are here.
Prognoma, you mean?
Yeah, melanotic prognoma? No. No. I did not think so, looking at these images.
In these regions, isolated soft tissue, because we've had a few rhabdoids present in a similar way.
Are rhabdoids MIBG positive? I'm not aware.
They're not MIBG positive, so that's
Correct.
where I was just wondering whether that's...
Even the morphology was more of a primitive embryonal round cell tumor. Going by the images, rhabdoids have very characteristic histology. They do have the rhabdoid phenotype, and it's evident on the simple H&E.
So neuroectodermal was my main differential. Could this be some other form of a neuroectodermal?
Yes, so that's why Ewing's or the peanut comes the second closest differential diagnosis.
Okay.
So MIBG probably has tilted the diagnosis towards neuroblastoma.
It did, for me, yes. It did, yeah.
Okay. So it was a difficult situation for surgeons, as Sajid sir was suggesting. In view of poor response to chemotherapy, the child was referred to pediatric surgeon, and the surgery was done at Bangalore Medical College, where we had plastic surgeon available. In fact, it was just debulking surgery, more than 50%.
Here that actually when we discussed, me and Gauri Shankar, we thought it could have been like what we were thinking exactly like what Sajid was saying, that we were worried about doing a craniectomy and going inside. So we involved our local neurosurgeons. They said, no, there's nothing much, you can just go and take it out. So we're not comfortable. So we sent it to another center where neurosurgeon, plastic surgeon, and pediatric surgeon available into one room. And they finally decided that, go ahead.
Debulking was done. Probably around 60-70% of the tumor was removed with the skin flap cover. Histopathology of this specimen was also suggestive of neuroblastoma. Now, since we were not able to excise the tumor completely, INSS stage was 2B, and histopathology, it was poorly differentiated neuroblastoma. So,
NMIC done?
Again, NMIC is not done. So this is where we are right now. What next, sir?
Testing times when you have a patient like this. And if you would like to fall back on evidence, I'm sure you'll not get evidence for these things. So you treat as per whatever best you can do locally, and for systemic, Tushar and the teams sir is there for management of that. The information would be is incomplete, and there is, now I would say there is no debate about the diagnosis, because we have a histology on biopsy, we have a histology on complete excision, and we have MIBG also. So there is no debate about the diagnosis. I'm not sure whether INSS 2B, but it is immaterial. It is irrelevant what stage it is now. It is now has to be treated in totality as a primary site only. So you take this as a primary site and you do whatever local treatment best. And since there is no direct evidence, yes, there is a role of radiation or not, I would prefer giving radiation in this situation. Lashkar is disagreeing, but I would like to consolidate my local therapy with some additional things, especially since we have evidence that it has not responded very well to chemotherapy.
They have not been able to completely excise. They have only been able to debug. That means there's still gross residue.
So how to
So I've seen nothing about this case so far that suggests it's a low-risk neuroblastoma. I know that people sometimes, we get excited when we see patients in infancy, that we hope it'll resolve, we hope it'll regress. But clinically or otherwise, I mean, this does not, I would categorize this as high-risk neuroblastoma, even without NMIC evidence, which is like, I think right now this patient is what, over a year and a half?
Yes, sir.
So patient is like over 18 months old. Patient is 19 months now. Patient has infiltrative lesion which could not be completely resected. I think you have to treat this as high-risk disease. I don't think you have the option of emitting radiation, of giving some low-dose chemotherapy and seeing what happens. We've already seen this does not appear to be chemosensitive to small doses of chemotherapy, which is what this patient previously received.
Specifically about the role of radiotherapy, can you just comment?
I think it would be challenging to give radiation in this situation, but seeing the way it has responded to chemo, like a poor response, I think it's better we give some additional radiation therapy. Maybe around 21 gray, we could probably be able to give it.
But I would start off with some decent chemotherapy like topotecan, vincristine, cytoxan based, or rapid Kojak based. I would start off with some more intensive chemotherapy, but I'll let Tushar and all the others and Siddharth and all the others in the audience add to that.
Dr. Siddharth.
So regarding radiation, I would look at two things. Number one, I would look at how much of the tumor has been actually removed and what is the residual disease, if it is a small little bit of residual disease. And I would also look at if you are really doing your NMIC or not. If you're doing your NMIC and if you have a high-risk neuroblastoma, you go ahead and do it, local radiation therapy. So I would look at two things to decide about radiation therapy. One is what is the residual disease left behind, and two, what is the NMIC. Now, gross could be a small little 5 millimeter gross, or it could be a 3 centimeter gross. So if it is a 3 centimeter gross, I would then tilt on this side, but I would also look at NMIC. So if it is NMIC positive, then there is no question. You have to go ahead and do it. Whether radiation is possible or not, yes, it is possible. What dose of radiation? You have to go to 25.2 in 14 fractions for gross disease. And if you have a very large disease, you can also escalate doses to 30.6 in 17. It's no point going beyond that. There is no dose response beyond that. So the dose between 25.2 in 14 to 30.6 in 17 fractions. But if it is a small 5 millimeters and I don't have NMIC, and then I would probably ask Tushar to do some magic. If he can, we'll hold on. And that is the rule for low risk and intermediate risk. Avoid radiation therapy as far as possible. For high risk, definitely go ahead and do it. In intermediate risk, if the disease is progressing for spine or things like that, after your standard treatment, then you intervene with radiation.
Okay. Thank you.
Again, Siddharth, would you like to have an external beam radiation or local? External. So again, anesthesia and that's a part of it.
Madam wanted to
yes, madam.
Yes,
listen to this theoretical discussion of if NMIC is negative and if NMIC is positive. In today's time, when you are first round, fine, you didn't do NMIC. At this point in time, I would say you have to do MLPA, not only NMIC. The child has presented before 18 months, and you have to look at both NMIC and 11q aberration, and then decide your line of therapy.
Point taken.
There is no shortcut to that.
Point taken. Yes. Actually, I had another case. We'll run through this
Quickly run through because this is very atypical. So we thought let's get something which is typical so that it can ease out the tumor board.
I'll just run through this. Antenatally detected bilateral suprarenal mass. The mass was identified at 7th month antenatal scan and the baby was delivered. It's a girl child, delivered at 8th month. Perinatal period was uneventful. On examination, there was a palpable mass in the left lumbar region extending from costal margin to iliac fossa, hard inconsistency, restricted mobility, renal fullness present. And on the other side also, there was a mass almost of the same size extending from costal margin to.
In summary, it was a bilateral disease.
Bilateral huge mass.
Huge masses with metastasis.
Ultrasound was suggestive of bilateral suprarenal region masses, solid and cystic components seen in both the masses. CCT confirmed the findings, and there were mets also. As we can see there, this was the CCT done at day 7 of life. Lung mets can be seen there. I'll just run through, sir. Any comments can be done, given there. And this is the liver. This is the suprarenal masses bilateral. It's looking more on the left. It's present on both the sides. Again, the left suprarenal mass displacing the kidney medially. Questions to the board. Is biopsy required here?
Rapid fire questions.
Differential diagnosis. And assuming that if it were to be an MS stage, although it's a M stage, what is the protocol for observation and how long can you?
Anywhere from the panel, you can take it quickly.
It's a cystic mass,
Yes.
but they're definitely solid area. It's a metastatic disease.
Yes,
no,
sir.
No doubt about it. It's a bilateral disease.
Yes, sir.
Especially the liver metastasis. Everything is thinking more towards MS disease. Is it MS disease? Is it a favorable MS disease? Is it unfavorable MS disease? Now, these are the questions which needs to be answered with a tissue diagnosis. If we have a tissue diagnosis, we get ancillary results like your NMIC status, the molecular status, the differentiation of the tumor, favorable, unfavorable. Those are the predictors of intensifying or not giving any treatment. So it's with MS. With MS situation, we have whether all MS do require treatment.
Should we label it as MS? Or
Should we
MS?
label it as MS because the information is incomplete? We didn't have a bone marrow. We have to
Bone marrow is done, sir. Sorry.
bone marrow is negative. Is negative. So only
Lung
metastatic.
mets is there, sir. So still
Lung
are we
mets.
taking it as MS?
Let me
MIBG, cortical bone involvement. Have we excluded cortical bone metastasis?
MIBG
So if this is only visceral disease and the bone marrow is not involved in an antenatally detected child, this is an MS disease. But we have to, for deciding further treatment, we need histological confirmation.
Definitely histological confirmation is required for NMIC also, and let me predict that NMIC was amplified in this child. Was it?
Sorry, histological diagnosis. No biopsy was not done here.
Parents are not, 70-year-old child, parents are extremely expensive, worried, they said it's a metastatic disease, so they're not very keen on further treatment, so they disappear.
So medical oncologist opinion was taken. In view of small age, oncologist suggested observation or surveillance with regular follow-up. In fact, the child came thrice to the oncology clinic up to 7 months of age and then disappeared. Again presented at 16 months of age.
This time, lo and behold, we were lucky.
On follow-up investigations, the right adrenal mass, lung and liver mets had showed regression. Left suprarenal mass had decreased in size, but it was persistent. Repeat CCT at 16 months was done. As we can see here, the lung mets had disappeared, the liver mets had disappeared, and the right mass had disappeared, the left had come down in size, and we were able to see a few calcifications. What next?
Finish. Yes.
How to proceed?
It has behaved like an MS, though we didn't do a histology, and probably we can assume that even the biology was good, and this was an MS which didn't warranted any treatment. The metastatic size have disappeared. The right side has disappeared, but the left side is persistent, probably because of the cystic component in it. And here we have almost a CR type of thing.
I agree with the panel, and I think you were extremely lucky in this child. But the lesson which the students need to learn is that the workup has to be complete, has to be extensive before labeling it as an MS and before observing it.
That's right. Here, the natural history of the disease has unfolded in front of us without us intending that. But yes, it has to be, the biology had to be proven.
Now, at this stage, should we still do a surgery, a biopsy, or an excision or an incision?
My basic question to you is, what is the blood pressure of this child?
It was normal. Yes.
Because the left-sided lesion, if you go back now, at 16 months of age, is quite close to the renal I saw in one very brief here. So I asked you.
It was normal.
It's normal.
Because sometimes that we had a similar child and it went on like that for more than 1.5 years. And then child had a persistent hypertension. And then the component increased in size, the solid component.
Yes,
and
we'll
then
go ahead.
we had to do it.
Thank you, ma'am.
So the question is what to do next. Should we excise it or should we observe it? We have seen over 10 months, almost a year of observation, and everything has regressed. Probably this is not regressing because of the cystic component. We know that the biology is very good. We can continue the observation. I would like to discuss with the parents, what do they feel now? Are they very apprehensive about having something in the tummy? I would not be hesitating if they say we want to get it out. So I am open for an excision, but at the same time, I am okay with an observation also with close follow-up.
At this stage, we discussed with the parents, and they were comfortable. They said you would rather get away with it, so we went ahead, and I think Narendra Babu exercised it.
So in view of regression and parents
And
insisting,
since it was very localized, we thought it will be fairly easy.
the intraoperative findings were encapsulated tumor arising from the left adrenal gland, had both solid and cystic component. The mass was displacing the pancreas and splenic vein medially. Adrenal vein was stretched over the mass. A left adrenalectomy with tumor excision without any breach in the capsule was done. And histopathology showed ganglion neuroblastoma intermixed. This image was taken from other, it's not a patient's image.
You're very honest.
And MIBG, there was no residual tumor after the excision. The other investigations were normal. This is where we stand now. Anything else needs to be done?
I'm okay with an observation only.
Observation.
Okay, I think we are running out of time. We need to wind up. Neuroblastoma is extremely, contentious issues. And obviously, there are a lot of different ways of presentation. What I would like to have is definitely, what is the take-home message for the trainees from all of you? One sentences will be happy. Neuroblastoma.
Okay, diagnostic point of view, a biopsy, histology mostly in more than 95% of cases, only biopsy without immunohistochemistry suffices. You don't have to run immunohistochemistry panel or markers. Save the tissue for molecular, and where molecular is mandatory, it has to be done. So that's my take-home message.
And
Don't waste.
NMIC and
Yes, so molecular testing includes NMIC and the other multiplex gene testing. So save your tissues, it's precious.
Sajid.
I'll be very concise. I'll not destroy my time with the diagnostic. I would say proper risk stratification. And the second part is regarding the local treatment surgery. Not all neuroblastoma require heroic surgery. There are many neuroblastomas which can be observed, and even the aggressive looking one, you need not be removing the last
Hold with good risk disease does not require the same aggressive strategy as, say, the 20-month-old with metastatic disease. So risk stratification up front is key. You can get away with it by playing the odds. You can get lucky, as Tushar said. But the problem in retrospect is if you don't get lucky, it's very hard to stand in front of the family and say, oh, we thought this would behave well, but it didn't.
I just want to say the role of radiation is very minimal, and it's very important that we discuss in multidisciplinary tumor boards and take the inputs of everyone before we radiate the kid.
This particular case, antenatally it was picked up. How short you are frequently scanning in prenatal, it will tell the tumor means progression, means the size criteria or the vascularity.
It was detected at 7th month, so probably delivery happened at 8th month.
So 2, 3, at least somebody picks up 15 days, 2 weeks interval or 3 weeks interval follow-up of USG will tell you the rapid progression of the tumor also, the vesicle.
Dr. Tushar, any particular input? Appaji sir? Purna Kurkare madam? I think you
No,
told.
I only insist on risk stratification because that is an investment to be made for every patient.
Appaji sir?
Tushar told investigate the patient and the 7-month-old child. You do biopsy, other investigation. What else? What we are going to do for the 7-month-old child? Parents will ask. 7-days-old child. We have to have something offer. We are not going to offer. Is it necessary to do the invasive investigation in a 7-month-old child.
So sometimes assurance is more rewarding than treatment. An assurance that we are sure of what we are doing.
Anyway, we are realizing that local regional factors are also playing even in the decision making. Shalini?
Or the perinatal neuroblastomas, they usually do worse and they will require some form of treatment. We usually see less than 3 months of age presentation, and we use the Philadelphia criteria to closely observe them if they have any respiratory distress, vomiting, any edema, failure to thrive, and we may need some small dose chemotherapy and just observation in our care.
Thank you very much. Is there any other thing? Okay. Deepak?
I thank all the panelists for their excellent inputs. Thank you very much, sir. Thank you, ma'am.
Thanks to Deepak too for carrying this.